So you've already learned about uncompensated ABGs. It's a review from NUR 180. Hopefully you've watched the video already and remembered some of the signs and symptoms and have already done the pre-quiz and understood the what you would expect to see in the treatment approaches for uncompensated blood gases. Now, your body is always going to try to maintain homeostasis. So it's important to understand that if a patient is starting to have partially compensated blood gases, because the body is always trying to restore a normal pH, and that's where it's going to work toward. It's important to understand that even though they're still partially compensated, we're going to still continue the plan of care, meaning the interventions that we used prior for uncompensated blood gases we're still going to use. Now, if the patient is fully compensated, that means that is their normal and we're not going to touch it. We're going to continue whatever it is to take their normal. So, for example, if a patient is fully compensated respiratory acidosis, this is a patient who is maybe a patient with COPD. They've had COPD for years and they take their steroids and bronchodilators on a regular basis. That is what maintains their treatment plan, and that's what keeps them fully compensated. We would continue the plan of care. Now, say a patient with COPD ends up with a pneumonia, now they become uncompensated. And so then we would have to change our interventions a little bit. All right. So in order for your body to restore its normal pH, it's going to go through a compensation piece. If metabolic problems are actually less severe than respiratory because the renal system really takes a long time to kick in, meaning it could take 5 to 7 days for the kidneys to say, hey, I'm going to catch up. So, if a patient has a metabolic problem, the respiratory system will kick in right away and start compensating. So, for example, let me show you this next slide. So right here, if I'm in respiratory acidosis, you already know that your pH is low and your CO2 is high. It's going to take 5 to 7 days for the kidneys to say, I'm going to hold on to some more bicarb, okay? So things that we can do in the meantime, although there are patients that get sodium bicarb as an IV infusion, we need to treat the cause of the respiratory acidosis. Why is the CO2 so high? Is it because they have a lot of mucus? They have alveolar collapse, they have bronchoconstriction. We're still going to treat this. Giving them bicarb is just a quick fix. We got to treat the underlying cause. Same thing with respiratory alkalosis. Why are they breathing so fast? Let's treat that. Otherwise, the kidneys will, again, they take too long. So for metabolic acidosis, remember you're looking at the pH and the bicarb. So what's going to happen is because you're already acidotic and you look at your CO2 and that's your acid, the CO2 is actually going to drop, meaning your respiratory rate is actually going to increase. That's how you get that CO2 to drop. So for example, a common cause of metabolic acidosis is DKA. So what do your patients with DKA normally do? Breathe that Kussmaul's respirations, that deep, hard, and fast. That's because they're trying to lower their CO2. That's the body's way of compensating. Now, say you give your patient in DKA a sedative to slow their respiratory rate down, you're really going to cause a lot of problems and actually probably and then end up putting them in respiratory acidosis. So always think about when your patient has a change in their respiratory rate. Is it because they're hypoxic? Are they trying to compensate for something? Always try to identify the cause rather than fix the symptom. Okay? And then so for metabolic alkalosis, your pH is up and your bicarb is up. So because you're alkalotic, your body is going to want to hold on to more CO2, so your respiratory rate might actually drop a little bit. All right. So let's practice. All right, so patient admits to feeling poorly for the last week. Here are the ABGs. pH is 7.30, CO2 is 28, and the bicarb is 16. So when you look at the pH, it's because it's lower than 7.35, it's acidotic. The bicarb is low, so when you look at Rome, respiratory opposite, metabolic equal, it's a metabolic acidosis problem. Because I'm already acidotic, your pH, your CO2, needs to be lower because this is my acid. So it's going to actually decrease. So it's a partially compensated metabolic acidosis. Okay? So you would expect that the patient's respiratory rate to be increasing in order to compensate for the already patient in metabolic acidosis. All right. So the difference with fully compensation is that the pH is actually normal, but you don't know where to draw the arrow because if the pH is normal, where do you start with your arrow? Is it up or down? So you're going to use the number of 7.40 to be your magic number. Anything between 7, remember its pH is normal, so anything between 7.35 and 7.39 or 40, don't worry, your test isn't going to be that specific. So 7.35 to 7.39 is going to be acidotic, okay? Alkalosis is 7.41 to 7.45, okay? And then, of course, you're going to have these two things being abnormal. If these two things were normal, you would just have a normal blood gas. These patients, we're going to continue the plan of care. We're not going to do anything different because they are compensated now. So let's practice. A patient with chronic COPD is being admitted for surgery. Before I even go further, I have a patient that's COPD, so I'm thinking respiratory, and it's chronic. So think fully compensated for the moment until you know better. All right, so the pH is 7.35. That's normal, so I'm going to move forward. CO2 is 48. Oh, that's high. Bicarb is 28. That's high. Now I'm going to go back to my pH because I know these are high and high. I'm going to go back to my pH and say it's under 7.40, which means it's acidotic. So I have and this is opposite, a respiratory acidosis, but because my bicarb is abnormal and this is a normal pH, it's a fully compensated respiratory acidosis. Okay. All right, a nurse is given a group of patients in their ABGs. Which patient should the nurse see first? So 2 I'm going to rule out immediately I'm going to rule out the 2 that are normal. Normal pH, okay? So now I need to go back to these 2. I have a pH that's 7.46, which is abnormal. My CO2 is high and my bicarb is high. So this means it's actually starting to be partially compensated. If this is up and this is up, so it's a metabolic alkalosis that's partially compensated. The respiratory rate has decreased in order to hold on to more CO2. This guy is starting to compensate already. But look at this one. pH is 7.26, CO2 is 55, and the bicarb is normal. So I have an uncompensated respiratory acidosis. This is the patient I need to see first. Okay. All right, hope this helps. There's a ton of practice, tons of videos to watch, and I have a practice ABG sheet that I'm going to post that I want you to work on. Let me know if you need any help.